I believe Anise sent out an email to sign up for that. If you didn't get it, you can send Anise an email here, anise@uw.edu. And then for next quarter, here's your registration code, 18250. Just go to the registration page, enter that in, and you should be good. We do have one event coming up real early next quarter. It's going to be before our first meeting, so Tim has a little more information about that.
Okay, so there's going to be a health fair that's being organized currently by the School of Pharmacy. It'll incorporate the School of Social Work, occupational therapy, the medical school, and the goal here is to provide comprehensive care for not only the geriatric population, but also the low-income population around Magnuson Park, Sandpoint area. This will be done in the Community Health Center down there. It'll be on January 9th. I'll be sending out information within the next few weeks to sign up, but basically we're going to be looking for about 10 to 15 students to come and help out and provide not only dental care, but also learn about what other professions have to offer for the geriatric and low-income populations. Thanks.
Yeah, so that should be a pretty good opportunity. It's going to be kind of like how what we've done at like Casa Latina, just oral screening and education, oral hygiene instruction, things like that. So real good opportunity. So look for that email. Other than that, if you do have any other questions finishing up this quarter, feel free to email myself or any of the AmeriCorps members. We do want you guys to kind of get everything done so that we don't have to worry about incompletes because, I mean, it's just not fun to have those, right? So try to get everything completed before December 11th and we'll be good to go. Without further ado, we have our own chief here. He's going to be talking about pediatric dentistry and preventative dentistry. So let's give him a big round of applause and a warm welcome.
Great, thank you. As you can see, there are days where I'm stuffy and I wear suits, but I try not to dress up when I can. So it's good to see everyone. Everyone here is dentistry, right? There are no any non-dental folks in here? No, everyone's dentistry. Okay, good. That helps. Okay, good. So what I wanted to do is as you all know, we have the 45th Street Clinic where we provide services 5 to 6 times each quarter. And what I wanted to do was provide you with kind of a framework to understand access to care for homeless youth. The example that I'm going to use is actually data from Iowa, but I think it actually is applicable, and I'm going to try to weave in the homeless population into what we're talking about. So all the data I'm presenting today, it is not on homeless youth, but I wanted to use this kind of as a launching pad for a broader discussion in terms of how to improve access to care for vulnerable children. Okay, so really there are 3 objectives that you should keep in mind as we talk today. By the end of today's session, and again, I know you all have a clinic at 1:30, so we're going to try to get you out of here a little early. We want to be able to identify the multi-level determinants of oral health for children, understanding and recognizing that it's a complex process in terms of ensuring that kids not only have access to dental care and engage in positive behaviors, but also have an opportunity to have good oral health. We're going to describe, or you should be able to describe, the importance of a dental home. And for you 3rd and 4th year students who are in clinic, the concept of the dental home should be something that's familiar, but we'll revisit that. And if you're not familiar with the dental home concept, you should be able to describe broadly what a dental home is and why it's important. And then we should be able to outline some strategies to improve dental homes as well as the oral health of vulnerable children, which includes homeless youth. Okay, so the multi-level determinants of oral health. Okay, so for those of you who've taken DPHS 510, how many first years are in here? Oh, a lot of you. Okay, good. So I haven't actually taught DPHS 510 yet. There's actually a course name change. We're going to change it to Dental Foundations. That's going to be next quarter. But for those of you not in the first year class, you'll appreciate that there are a lot of factors that go into whether individuals have oral health or good oral health versus poor oral health. This is a model published in pediatrics. This was published well, I guess it was long ago. I guess it was about 8 years ago.
And what this model shows us is that there are multiple influences that go into whether or not a child or a person, an individual, can enjoy oral health or has oral health. Now, if you look down here at the three-circle diagram, that three-circle diagram is probably something you all have seen in your restorative courses, in your microbiome courses. This three-circle model really is what drove a lot of dental research up until probably about 10 or 15 years ago. And it's this idea that you need bacteria, you need substrate or dietary sugars, and then you need teeth to actually have this caries process happen. Now, one of the reasons why I think that there weren't a lot of improvements based just on this three-circle model is that it doesn't account for all the other factors that go into whether or not someone has oral health or good oral health. And so really, if you stick these the three circles into the oral health circle that's kind of at the center of this diagram, what this diagram shows us is that the factors that are related to oral health go beyond just those three factors. There are factors at the child level, so we see here use of dental care, development, dental insurance, health behaviors and practices. So those are kind of the things that are happening at the child level that influence whether or not someone has good oral health. And then there are family level influences, the socioeconomic status, social support, culture. And then there are community level influences, so what's happening in the neighborhoods, what's happening in the broader community. So with this diagram, it's not a fully exhaustive list of all the factors related to oral health, but it shows us that there are factors beyond just sugar, tooth, and bacteria that actually either promote oral health or inhibit it. So when we think about homeless youth, what are some of the barriers to oral health that homeless youth might face based on this diagram? And this is where we open it up, and I think, do those little buttons still work, or do we not use the buttons?
The buttons work.
The buttons work. Okay, so use your buttons so everyone can hear. All right, so what do we think? You have the keys up pressed.
Okay, not like that.
Oh, okay, or it's broken.
It's like struggle less and hardcore. I feel like with the homeless youth that we've got, I think just being able to access dental care, I think when we were working at the 45th Street Clinic, I remember very distinctly because it blew me away. This young man came in and he said that his biggest struggle in being able to brush his teeth is having a sink to brush his teeth in the morning. And so that's something that you wouldn't even think of as being a problem when you're so used to having a sink. But he said that you really wouldn't have access to a sink until about lunchtime, and by then you're probably out doing something else. So, I think that having access to even brush your teeth, having access to get your teeth taken care of, cleanings, all applies to the homeless youth population.
Absolutely. So you think about the physical, barriers to oral health, and you're totally right. We did a survey when I was a dental student. We did a survey with homeless youth, and one of the barriers we found was just having the materials to brush one's teeth. You're right. So not just toothbrush and toothpaste, but right, having the physical resources to be able to engage in everyday oral health behaviors, becomes a challenge. So this isn't even how do you get these kids into the dentist? It's how do you ensure that these kids have a place to brush every now and then, let alone twice a day. Good. What else? Yeah.
Many of those kids have other priorities.
Like what?
Like trying to find a way, where are they going to sleep that night? How are they going to survive over the next couple of days? I think all that usually takes a precedent over their, whatever they feel about their teeth.
Right, so there are probably more pressing needs that may become prioritized over oral health. And really, when you think about oral health behaviors, which we'll go over briefly, when you think about oral health behaviors, they're really an investment in the future. While we all benefit immediately from having good breath after we brush, really when you think about the longer term benefits, it's to prevent cavities, it's to prevent gum disease. You go to the dentist so that you can get oral cancer diagnosed and screened earlier. There's really an investment involved. And when you think about homeless youth and some of the priorities that they may be coming in with, as well as some competing interests for their time, many homeless youth may not be thinking longer term, which could get in the way. Sure. What else? Yeah.
so maybe more affordable for them to eat high carbohydrate foods, or just like a dollar burger from McDonald's rather than getting some vegetables and fruits.
Absolutely, so dietary choices. So when you think about the app, there's a big Jack in the Box there on 50th in the app, and what they have jumbo jacks for like $1.50 or $2. Again, these healthier foods are more expensive. And so what's easier? It's easier to get cheap foods. Like, there's a 7-Eleven or multiple 7-Elevens on the app, and you can get, 3 donuts for $1 or something. So comparing that to like a banana or something else that might be healthier. And then when you combine that again with the short-term versus long-term investments that we make when we make better dietary decisions, again, healthy diets may not be, on the radar. Yeah.
Going off that, a lot of their education is going to be coming from kind of billboards and advertisements, especially, I guess, with oral health. So if they only have a few dollars, even the cheaper food's going to be what they're going to get, and they don't really realize that a banana is going to be better than a candy bar. Education.
Yeah, so there may just be some general knowledge deficits. So when you think about homeless youth, you could have older kids who may have completed high school, who may have had some college and are homeless. But there's a pretty large population of homeless kids who may be dropouts, who may be high school dropouts, who haven't completed school, or have become homeless, through processes that maybe they ended up homeless, when they were much younger. So there may be some knowledge deficits. What else? So for those of you who have been to the 45th Street Clinic, what other things are you seeing, or what other things have you seen in terms of barriers to oral health? Yeah.
Not being aware of where to find dental care, and so not knowing where exactly there's a free clinic for them.
Right, so the actual facilities. So there might be, facilities like the 45th Street Clinic that offers care every Thursday night. But you may not know that it's offered every Thursday night, so just even knowing where to go, or not knowing where to go can be a barrier. What about drug use? Big problem in this population? Illicit drug use, prescription drug use, other drug use? Right, so drug use is another big potential issue. And if you look at this month's edition of the Journal of the American Dental Association, there's actually a pretty good article on methamphetamine use and oral health outcomes. And we know that meth is a big problem in homeless populations. So there's a variety of different issues. And obviously I think that the take-home message here is that that really is a complicated issue. And coming up with solutions is even more complicated. Okay, so the social determinants of health disparities. So we know that there are social factors related to why certain folks get disease and others don't. Race ethnicity is probably one of the strongest predictors of whether someone's going to have tooth decay. So based on the most recent national data, this indicates the percentage of kids by race ethnicity group that have had tooth decay experience. So we can see here that using the purple or the white kind of as a baseline group, minus the other Hispanic group, all the other non-white racial groups or ethnicity groups have higher rates of tooth decay. So we can see here that Mexican Americans, nearly 60% or over 60% of Mexican American children in the U.S. Have had, an experience with tooth decay, compared to about 42% of whites. So we see here that race ethnicity plays a role. We also know that income is a strong predictor of tooth decay. We can actually see a nice income gradient here, whereas income to poverty ratio, as that goes from less than 1 to greater than 5, we have a decrease in caries rate. So what we see here is that the more lower income you are, the higher rates of tooth decay you're going to come in with. So we know that income plays a role. But beyond the social factors, some of the more immediate factors related to oral health, we think about behaviors. And this is something that we'll talk about in Dental Foundations 521 for the first years, and that we talked about in 510 for the non-first years. We know that oral health behaviors are innate or learned activities, and that there are 3 main behaviors implicated in caries. So we have toothbrushing with fluoride toothpaste, we have diets low in sugar, and then we have dental visits. So we know that these are the 3 main behaviors. If you engage in these behaviors, chances are you're going to be able to prevent most tooth decay, which then can lead to good oral health outcomes. So the importance of a dental home. So what I'm going to do is present some data. These are actually hot off the press data
from Iowa, looking at dental homes and preventive dental care use for children in Medicaid with autism. And autism is kind of, when I think about children with special health care needs, autism is kind of a prototypical condition where when you think about some of the barriers to care for children with autism, some of the prototypical barriers to care are going to affect kids with autism. So we're using autism as kind of a case study to understand broader barriers to dental homes. So we know that kids with special health care needs, especially kids with autism, encounter tremendous barriers to oral health. The two main factors is that, really there are factors related to having a special health care need. So we talked about competing interests when you talk to families of kids with special health care needs. Families oftentimes will talk to you about, well, we have a whole bunch of other things to worry about. We have medical care, things to prioritize. There are school issues going on. There are mental health, care needs that need to be met. Lots of things going on beyond just dentistry. So then dentistry becomes a less important priority. But we also know that cognition and behaviors are a really big barrier for kids with autism. So how many of you have seen a patient with autism in clinic? Tell me about some of the behavioral challenges that a provider might face in treating a child or a patient with autism. Sarah, I saw your hand in the back.
Well, definitely the spectrum, so I think we see some that are more severe than others. A lot of my patients with autism have had some pretty severe dental fears, and I think a big reason is because it's hard for them to communicate exactly what they feel and what's uncomfortable for them. So those are most of my experiences.
Absolutely. So autism is a spectrum disorder. So you're going to have severely affected individuals and then less severely affected individuals. And when we think about the more severely affected individuals, patients may have a difficult time saying something bothers them, or that something hurts, or that something that they don't like the light in their eyes or near their eyes, which could lead to dental fears. Absolutely. What else? Yeah. Oh.
Sorry,
Perfect
I took a bite. I would say building trust was a huge step in that appointment that I had in Decode with the autistic child. He just wanted to know everything that was going on, would get distracted, but then we'd keep him on task. But so I think that was a very important part of that. And just communicating might have been a little challenging, but as long as you can do that, I think.
Now, building rapport and trust, absolutely. Now, did that happen over one visit, or did that happen over
No, so we had
visits?
to do like an orient appointment where we just kind of test out laying in the chair, the light, like everything like that, and then bring him in and actually do the appointment. But,
Absolutely.
Yeah.
So a lot of times, building rapport, it can happen during short dental visits, but it may take multiple dental visits for some patients. And when you think about the private practice model, many private practice offices may not be equipped to incorporate that type of recall into their schedules.
it's not only with the patient, but a lot of time, or at least in my case, the parent was there.
Sure.
And so they kind of, they also have a process of building trust with you, and being on the same page is important there as well.
Absolutely. Right, because if the caregiver doesn't trust the provider, what are the chances the caregiver is going to bring the child back regardless of whether the child wants to? Yeah, absolutely. What other barriers when you think about patients with autism? Yes.
A lot of the time they aren't showing up by themselves, they're relying on someone else to transport them or make the appointments for them, and basically, if that person isn't on top of all that stuff, it just doesn't really happen.
Sure, absolutely. So when you think about kids or adults who again may not have the cognitive abilities to make their own appointments, drive themselves, you become dependent on a caregiver. And so if the caregiver is less reliable, or the caregiver's car breaks down or something, it makes it really hard. So hopefully you can actually see the parallels between, again, we're using autism as an example. But when you think about building trust, when you think about not being able to communicate, dental fears, when you think about reliance on individuals beyond, the patient, there are a lot of parallels between, kids with autism as well as homeless populations. Again, similar types of barriers to oral health. Yeah.
Another similar barrier I just thought of was home care. So autistic children, it kind of varies on how dedicated or willing they are to participate in brushing their teeth every day or twice a day or even weekly. So.
Absolutely right. So if you're depending again on a caregiver to enforce those behaviors, again, homeless kids are kind of the same way. They may have to rely on themselves and they may not have the skills or the habits developed to rely or to do these behaviors on their own. So we know that most kids with autism are in Medicaid. So Medicaid, we know, is a program aimed at low-income populations, and it's a health insurance program. So it gives low-income populations both medical and dental insurance so that they can access care. We also know that while Medicaid is effective, generally speaking, there are subgroups of children in Medicaid who have difficulties accessing dental care, which then leads to high levels of unmet need. So when we think about a dental home, really, the dental home is broadly speaking, in layman's terms, a place where people can go for preventive care as well as restorative and emergency care after hours. When you think about broadly what a dental home is, it really goes beyond that. It's based on the medical home concept. And it's based on this notion that it meets all of these criteria that are on this slide. So, care that's easily accessible, care that's comprehensive as well as coordinated and culturally competent. It really, the dental home concept contains, a whole lot of different things other than just a place where you get dental care. And really our goal is to ensure that kids, vulnerable kids and youth, have a dental home, because we know that kids who have established a dental home from an early age, we know that those habits tend to follow these kids into adulthood. So it's really important to actually develop these habits from an early age. So Medicaid has come up with multiple programs, or multiple Medicaid programs have come up with special programs aimed at improving dental home rates for kids in Medicaid. So some of you may know that the prototypical program, when we think about access programs, is happened here in Washington State with the ABCD program. So back in '95, ABCD started, and it was aimed at improving dental home rates for kids in Medicaid under the age of 6. So to get these really young kids in early, get them the preventive care that they need as well as the restorative care, and then get them into the dentist regularly after that. And when we think about programs after that, really, they're similar to ABCD. Into the Mouth of Babes is in North Carolina, and then the iSmile program is in Iowa. And these are very similar programs. And at the root of these programs is that they're community-based programs that are family-centered, that help families coordinate the care. So we talked about the role that families play in terms of getting kids to the dentist. And if you can get families on board and help coordinate some of the care, the idea here is that maybe kids can get in a little easier. So based on data, based on national data, we know that these programs are broadly speaking, that they're working. So we see here with the blue and the red bars here, these are utilization rates for kids both under the age of 3 and then between the ages of 3 and 5. And this is the proportion or the percentage of kids who utilize dental care. And these are Medicaid utilization rates. So we can see here, I want you to pay attention to the blue bars in particular. We know that kids don't get to the dentist at an early age. So that first dental visit is recommended at age 12 months. And we know that less than 5% of kids have their first dental visit by age 1. So this benchmark looking at the percentage of kids who get into the dentist by age 3, it's kind of a good benchmark in terms of how a state is doing overall for the youngest kids in Medicaid. And we can see here that, compared to these rates, again, the national rate I think is somewhere around 3 or 4%. Washington is up above 20%. North Carolina is close to 30%. And then Iowa is also hovering around 20%. Meaning that these programs, that generally speaking, that they're working, that they're effective when we think about broadly young kids and then dental care utilization rates. Now what I'm interested in is that we have these broad programs like ABCD, Into the Mouth of Babes, and iSmile. What I'm broadly interested in is unintended benefits as well as unintended consequences. And what I mean by that is that for unintended benefits, really these are spillover effects that might be happening. So this is based on the notion that, let's see, okay, so you have ABCD. ABCD is geared toward kids under the age of 6. But spillover effects might be something like, okay, well, there's this program for young kids, but maybe this program also helps to get older kids in Medicaid to the dentist. And the idea here is, for instance, a younger child might have an older sibling that a dentist is then willing to see, who might not otherwise be willing to have seen that child. So we have the potential for unintended benefits
which again we're calling spillover effects. The unintended consequences of such program, one example is crowd out. And the idea here is that when you think about who's best equipped to benefit from programs like ABCD, what ABCD might be doing is that it might be skimming off the top. So those families who maybe just need a little bit of help to get their kids to the dentist might be benefiting and taking up all the spots in dental offices, leaving a whole bunch of kids still without dental care. And so this is the possibility for unintended consequences associated with programs like ABCD. And as those of you who have taken my course know, it's really important to be able to evaluate these programs so that we can better understand the broader effects of programs, because this has implications for how we tweak these programs in the future. So using Iowa Medicaid data, we tested two hypotheses. So we hypothesized that kids with autism would be less likely to have dental homes than kids without. And then we also hypothesized that kids with autism would be less likely to use preventive care. And preventive care here is defined as either fluoride treatments, sealants, or cleanings. So we looked at data from 2003 to 2011, and we ran some regression models here, and we're looking longitudinally, or over time, what's happening to these relationships between having autism and then either dental home rates or preventive dental care use. And so these are the three time periods, 2003 through 2011, chopped up into three distinct time periods based on when iSmile was implemented. And we use CDT codes, which are the billing codes, to look at utilization. So broadly, what we found was that kids over the 10-year period, only 8% of the kids in our data actually had a dental home. So what this means is that only 8% of the kids actually saw a dentist 2 times within a given year. So this is for all the kids in Medicaid. And then about 50% of kids utilized any preventive care within a particular 12-month period. So our first hypothesis is that we wanted to test whether kids with autism were either more or less likely to have dental homes. And what we found here is that overall, as well as during those specific 3 time periods, that there was no difference in dental home rates for kids with autism versus kids without. So no difference in dental home rates. So this actually goes against our hypothesis. We have hypothesized that kids with autism, because of a whole slew of factors, that they'd be less likely to have dental homes. But what our data show is that that was not the case, that dental home rates were similar for kids with and without autism. However, this is where it's interesting. What we found was that during the later periods of iSmile, as well as overall, we found that kids with autism were significantly less likely to get preventive care compared to kids without autism. And so when you combine these two sets of findings, it's kind of an interesting set of findings, So these kids with autism, they're equally as likely to go to the dentist or get into the dentist for dental visits, but once they get in, they're not getting as much preventive care, which is really an interesting question or an interesting dilemma when you think about the risk factors that exist for kids with autism. So an interesting set of findings, and we don't really know what's going on here. But that really is going to be the next set of research questions that we ask. Because what's happening once these kids are actually getting into the dentist? Why aren't they getting preventive care at similar rates, at least, compared to kids without autism? Now, some limitations here. Our operationalization of dental home is restrictive. We were using CDT codes, and based on my previous slide, we know that the dental home concept is made up of a whole bunch of other things than just getting into the dentist twice a year. And the other thing is, really we may need additional years of data to look at these questions further out to see, if it takes a little more time for iSmile to actually do something for kids without autism compared to kids with autism. And the other thing is, we know that dental visits aren't the be-all, end-all solution. So when you look at this diagram, that little red star basically is where dental use is. This is part of the equation. And so I think, sometimes as dentists, we focus heavily on dental care use as being like the most important thing. And what I'm arguing here with this diagram is that it's part of the solution. That dental visits and preventive care are important, but really there are going to be multiple other things that are involved in enhancing and promoting oral health. So in terms of next steps, we have a whole bunch of research questions as well as clinical questions that we're interested in asking. And really, I think the main take home here is that there are a lot of kids, a lot of vulnerable kids who aren't getting into the dentist regularly. And what is it that we can do for these kids so that they're able to benefit from preventive care, as well as some of the anticipatory guidance and monitoring that happens during these dental visits. And really that is the next step in terms of trying to figure this out. So I want to bring it back to dental homes as well as oral health for homeless populations. And we've talked a little bit about some of the barriers to care and the barriers to oral health that kids with autism may face, kids with homelessness may face. But what are some broad challenges and opportunities in terms of promoting dental homes for homeless youth? And I think this is where I wanted to open it up and kind of do a brainstorming session as to what you all think the challenges and opportunities are. Yes?
One of the challenges would be funding. Who's going to fund these oral homes? In the long term.
So funding, yeah, absolutely. So funding, what we rely on now is a lot of charity work. And so we rely on providers to give their time or volunteer their time. And then a community health center like the 45th Street Clinic may have to just offer the clinic as well as supplies kind of on a charity basis. And so because there's not systematic funding for healthcare services for homeless populations, funding is always a big challenge, absolutely. So how do we get around that? So for every challenge that we mention, we want to come up with either an opportunity or a solution. So what would we do to address that problem?
Maybe more, seeking out more charity support.
So more, yep. So recruit more charities to do more charity work. Sure, that's a possibility. What else? Let's think more broadly. Sure.
Grants from the government?
Grants from the government, sure. So maybe the government needs to put together some funding opportunities to make these things more available. Yeah.
Just because we're going to find out the cause of teen homelessness and maybe work with high schools and counselors to try and stop that.
Yeah, absolutely. So when you think about like going all the way upstream, absolutely. So getting at the root of really what's causing this homelessness, as a problem. And how can we get to the root of that? Absolutely. So I would say if you were to go all the way to the root of the problem, that certainly would be something worthwhile. And how much really investment does the government make in terms of doing that? Not very much. So there might be a couple of NIH research projects going on in terms of addressing these types of issues, but systematically speaking, not a whole lot going on in that area. So what else? What other challenges exist in terms of providing dental homes?
Retention of your patients and making sure that they come to the appointments when they're supposed to. I think a lot of them might be coming from farther away. So they miss their bus, or if they have their home, they get a sign and forget.
Yeah.
Possible solution to that would be reimbursement for bringing your bus pass in, and we'll pay the 275 or something. And then try to open up more dental homes so that they don't go far.
Sure, absolutely. So let's assume, the funding issue is always a big problem, back to problem number one or challenge number one. So let's say the federal government opened up a whole bunch of homeless dental clinics for homeless populations. The issue that was just brought up is a huge issue, and we have this issue at the 45th Street Clinic, where we have the clinic open, actually it's open every Thursdays now, so the days that we're not there, there's a dentist there providing care on Thursday evenings. There are some evenings where there are no patients. And so we know that there are homeless kids out there that need dental care, except they're not in the dental office when services are being provided. So I think the issue of maybe coming up with ways to incentivize youth to actually seek care might be a way to address this. And actually this has been tested not in dentistry, but in general healthcare. And it's based on behavioral economic principles. So it's based on this idea that if you can incentivize people to participate in accessing dental care services or engaging in health behaviors or maybe preventing a disease, that you may need to incentivize individuals to actually partake in this. So absolutely, and that hasn't been looked at carefully. But again, for select subgroups of patients, that may be what it takes to get these patients to come back in. Absolutely. What else? What other challenges have you all seen? What can you think of?
Creating awareness of where treatment is available. I know at the Seattle King County Clinic, I had patients who were really happy to be getting treatment there, but weren't really aware of other places they could go to get treatment following that.
Right, and we're relatively spoiled here in Seattle King County, where we generally speaking have a lot of services, a lot of social support, as well as outreach services for homeless kids, as well as homeless populations. But you may live in a community, or you may end up practicing in a community where those resources don't exist, or they're really sparse. And what ends up happening in those situations is that care is kind of provided sporadically, so that people don't know when it's being provided or where it's being provided. And then it's just, the broader issue of, if you have homeless, populations that don't know about these services, how is it that you can get the word out? And that's a big challenge with the migrant population that's moving around a lot. Yeah, absolutely. What else? Yes.
I suppose one of the challenges might be if you're limited in your funding, you might be limited in what kinds of procedures you're able to offer to your patients. So I suppose one solution might be to come up with cheaper forms that have the same kind of effect.
Like what?
Maybe like fluoride varnish is like a cheaper way to provide fluoride. The silver compound.
Silver diamine fluoride, yeah, so Dr. Milburn was here, was it last week or a couple of weeks ago, talking about silver diamine fluoride. Yeah, so this is where, again, silver diamine fluoride is it's for those of you who've been to Longview, you've used it or seen it, that's a potential chemotherapeutic that could be incorporated into community-based programs. So at least, you're not providing, again, you're arresting caries. You might not be providing the definitive care, but you're arresting the process so that, that patients can stay out of pain. So absolutely. The issue of specialty care, I think, is a big issue, I think, when it comes to these types of clinics. And this is why, community clinics, or not community clinics, but these charity clinics, or these specialty clinics, a lot of times they don't address the problem systematically or comprehensively. Because what if someone comes in and needs endo, or needs pros, or needs a crown? A lot of times we can't provide those services. And how is it that we can get the type of care that individuals need? And again, that's a big question, because funding is an issue. Workforce is a potential barrier there in terms of getting specialists there. Even if we refer these kids out to specialists, what are the chances that these kids, even if the care is free at the receiving end at a specialist office, what are the odds that this kid's going to follow through with that? Some kids are not going to follow through, so that becomes a problem. Absolutely. So again, I think this highlights the fact that I think when we think about solutions, and what we're trying to address with the 45th Street Clinic is a problem that homeless youth face. But even we all have good hearts, and we all show up after hours working hard. Even though we're doing this, I think there's a recognition that this is not the be-all, end-all solution, and that there's really are broader policies that are needed to address these problems. The root cause of homelessness, I think that's a great point that was mentioned. But also funding, as well as programs that specifically target this population, that keep in mind these barriers to care, like kids who don't come back for care, or kids who don't have transportation. Okay, when we think about coming up with a comprehensive solution, this program ends up being pretty big. It's a pretty hefty, big program, and big, hefty programs cost a lot of money. So it's something to think about. So really, I think the take-home message is here is that, based on the Iowa data, we know that subgroups of kids in Medicaid, that they're at greater risk for disparities. So we found that dental home rates weren't different for kids with autism versus kids without autism. but we found that preventive dental care utilization rates were. I think what this shows us is that broad health programs like iSmile, again, may not address disparities comprehensively, and this is where we need to think broadly about what the solutions are. So the importance of identifying subgroups within these broad health programs is important, and then tailoring approaches to these high-risk subgroups. And one of these subgroups might be homeless youth. So when you think about homeless youth, most of these youth are going to be eligible for Medicaid. Most, if not all of them, are going to be eligible for Medicaid. But how many of them are actually coming in with Medicaid insurance? Not very many. So when you look at the homeless population at the 45th Street Clinic, even though most of these kids are eligible, they're not coming in with even Medicaid insurance, which as a provider, then you're really getting zero. At least with Medicaid, you get 40 or 50% of your costs reimbursed, but with no insurance, you're not getting anything back. And that kind of ties in with the whole sustainability issue of how these programs are supposed to be self-sustained over time. And then really the need for broader social policies to achieve equity, which in the end, hopefully is our goal, to make sure that populations have an equal opportunity to benefit from oral health. And if any of you were here for Nancy Krieger's talk a couple of weeks ago during the Homeless Symposium, that was her main argument, is that we need broader policies to address these problems that we have in society these days. And interventions, may not be the only way to address this. Really, we need broader policies passed by the federal government to help address these broader problems. All right. So with that, any questions? And we'll open it up for discussion. And thank you very much for giving me an opportunity to stop by.